I'll be introducing MIGS and intraoperative gonioscopy. So I'm Dr. John Davis Akkara. I'm a glaucoma, cataract and refractive surgeon at Western Eye Hospital and Chaitanya Eye Hospital in Kochi. Let's first start. Firstly, financial disclosures, no financial interests. What is MIGS? It's micro-invasive or minimally invasive glaucoma surgeries. Here you can see some eye stents, and this is an eye stent W which has a wider base. This is a model of the Kahook dual blade. If you see, there is no financial interest. If you see, these are all much smaller than they are made out to be, not to scale. And a special thanks to Dr. Prasanna Venkatesh, who is supposed to be presenting here, but unfortunately he had a small accident yesterday, so he won't be presenting. We'll be presenting for him. Special thanks for all his work on MIGS. His presentation is also here, and some of the slides of this are also from Dr. Prasanna. Special thanks to him. So what is MIGS? There's a bunch of glaucoma surgery, the newer glaucoma surgeries, which usually have an ab interno approach, that is from inside, with minimal disruption of the anatomy. So that means even if a MIGS fails, you can still do a trabeculectomy if that is what is required, or a tube surgery if that is what is required. And we try to make it as efficacious as possible. There are various MIGS surgeries which have been attempted. Some of them are less efficacious than others, so we will be looking at that. Have a high safety profile. So that is one of the main advantages compared to trabeculectomy, where you might have hypotony, you might have risk of infection, you have a lot of other things where you disrupt the anatomy a lot. There's a high safety profile here and the ease of use. Most of the MIGS surgeries are quick, and you can just finish it off at the end of phaco emulsification. You can do it combined as a part of this. So if you ask why MIGS, you look at what patients require MIGS. You look at mild to moderate open angle glaucomas first, and even pseudoexfoliative glaucoma or pigmentary glaucoma, where the block is at the angles. You look at cup disc ratio of less than 0.8, because if it is more, you might need a more aggressive surgery like a trabeculectomy. Preoperative IOP may be up to 30 with medications. Target IOP, you look for something around 15. Don't look for much lower than that. You can take phakic patients or pseudophakic patients. If it's phakic patient, you can do a combined cataract surgery plus MIGS. So you can look at patients who have difficulty taking chronic glaucoma medications with side effects or otherwise, or poor compliance. So all these, like to avoid medication, you can do that. And even with medication, if you want a little more reduction of IOP, and of course the angle anatomy by gonioscopy, you have to look and see that the angles are good before you attempt this. Any of these problems, peripheral synechiae, rubiosis, or any angle abnormalities will impair your ability to put a proper MIGS implant or do MIGS surgery. These are some of the MIGS implants and surgeries available. There is a bunch from iStent. So this is the old iStent and the iStent Inject W. We saw these two pictures. iStent Supra, which goes in the suprachoroidal space. Hydrus, which goes into the Schlemm's canal. Cyprus, which goes into the suprachoroidal space. Solex Gold also goes in the suprachoroidal space. And of course Zen and Preserflow, which go into the subconjunctival space. So this is a hybrid between MIGS and lesser than trabeculectomy. Then there is bent and needle goniotomy, which we'll be talking about, which is probably the most inexpensive, most economical one to start with. Then there is a Kahook dual blade, which is also mostly economical and is an angle surgery. GAT, gonio assisted transluminal trabeculotomy, where you go and de-roof the Schlemm's canal 360 degrees. And this was first done with a catheter, fiber optic catheter, so it was more expensive. Then came the suture gat, which Dr. Mahesh will be talking about, where it is much less expensive now because we are using a Prolene suture. And there is the trabectome, which again de-roofs the Schlemm's canal. And this one from Otley, high frequency deep scolectomy, again de-roofs the Schlemm's canal. Ab interno canaloplasties, then Tanito microhook, and streamline. So this is the Cahook dual blade, and this is the eye stent injector. These are the ones which are easily available now in India. Before you go into MIGS, you need to know about intraoperative gonioscopy. So you need a direct gonio lens. And to practice, you can maybe start with using a Sinskey hook just to get accustomed to going to and from the angle. A cohesive viscoelastic, which is sodium hyaluronate 1.6%, 1.4, 1.6, both are available. The more the higher concentration is easier to use. And you can use either a handheld Swan Jacob type surgical gonio lens, and you can place it across like this, and the cohesive viscoelastic helps here. And you can also use a TVG lens, which stabilizes the eye as well and gives you more freedom to move around. But there are also hands-free gonio prisms now, which stay with a good cohesive viscoelastic. You put a good cohesive viscoelastic here as well as inside the eye, and that cohesive viscoelastic helps you keep this there without holding it with one hand, freeing up both hands to control the eye. So these three, the hands-free from Catena, the Secure Flex from Ocular, and the Eye Prism SX from Oculus, or from Glaucos. This is from Glaucos. All of them are hands-free. So this is the Eye Prism SX from Glaucos staying on top of an eyeball model, and here I think it's a Catena here. This is a Cahook dual blade, and there's also the Oculus Gonio Ready, which attaches to the microscope, which is also slightly more convenient but also more expensive. So that is one option. And Dr. Prasanna will be demonstrating here the positioning. Positioning is you need a tiltable microscope. So you have to tilt the microscope like this. So it's around 30 to 45 degrees. And this is an important tip. You can mark the position so that the assistant can tilt it for you, because once you're scrubbed in, it's difficult. And so once you also need tiltable eyepieces for best option, and also you tilt the patient's head away 30 to 45 degrees. Okay, so that is how you adjust a microscope. This mark is very useful. And tilt the patient's head away and tilt the patient's tilt the microscope towards you. That is how you get to the angle. And you have to reduce the blood coming into the angle. So keep the patient's head above the heart, tilt the OT table to prevent blood reflex from the Schlemm's canal. So if you do this, you will reduce the most common problem with MIGS, that is a blood reflex into the anterior chamber. This is Dr. Prasanna showing the TVG lens. Which is much more expensive but gives more stability, but I think one of these hands-free lenses will be most economical and useful right now. So make sure it is a highly cohesive 1.6% sodium hyaluronate, and then once you put it, you can get an angle view. The other presenters will be talking about all these things which are available in India, and you'll get more tips and tricks for MIGS from them. So this, if you see, you can see the angle, and this is how Dr. Prasanna is going towards the angle to show you. Right, this is how he makes the cut. So thank you. That's an